Welcome to the Healthcare Unfiltered Express, where I conduct short video interviews packed with relevant and timely information that you cannot miss. So sit back and enjoy the show. The formidable Petros Grievous on Healthcare Unfiltered Express. We have the Express version, my friend. Thank you so much for coming.
Thanks so much for having me, my friend. Excited from ESMO, ECOG, Akron, Migos. Many meetings are happening this fall, and it's amazing to discuss the data.
I think you spend more time on a plane or in the skies than on the ground. I think I'm convinced of that. But today we wanted really to cover a little bit of the ESMO 2025 urothelial data, which I think you probably took the trophy this meeting. I actually spoke with Bishoy Faltas, our mutual friend, from the translational standpoint. How is the information from ESMO 2025 affects the translational work, the research work is gonna happen in urothelial cancer. But with you, we're gonna focus more clinically into what happened. A lot of stuff. So it's your show. So tell me what we should know about and what should listeners and viewers understand.
I am so happy you spoke with Bishoy. He's brilliant and amazing guy and has done so much work on the translational field. And he's also working on some interesting neoadjuvant trials like Clonivo. So I can tell you this ESMO 2025 was amazing in Berlin in terms of the data overall, GU cancers, and particularly bladder cancer. I'll give you a flavor study for the three presidential symposium talks that happened at ESMO. I will start neoadjuvant, then I will go adjuvant and then metastatic. So in the neoadjuvant space, we had the context last year from the ESMO 2024 of the Niagara trial. Tom Pauls gave that presentation last year. Gemcis neoadjuvantly plus perioperatively, neoadjuvant adjuvant durvalumab, it was shown to be superior to neoadjuvant Gemcis alone in terms of pathological complete response rate, event-free survival, and overall survival, representing the new standard of care for cisplatin-eligible patients. Interestingly, in that trial, there were patients that they went down to the GFR of 40. So patients with a GFR between 40 and 60 that were enrolled in Niagara trial that were not enrolled in prior cisplatin-eligible trials. So they expanded that definition. So with that context in mind, we saw data from EV303 or Keynote 905 trial. Krzysztof Wulsticki from Europe presented this data very nicely on Saturday afternoon. And this was a trial in cisplatin ineligible patients, not eligible, and they amended the protocol midway and they allowed patients, it was about 20% of patients who declined, refused cisplatin that they were enrolled in that study, EV303. Design was perioperative EV Pembro, 3 cycles neoadjuvantly, radical surgery, and then adjuvantly, 6 cycles was the intent of combo EV Pembro adjuvantly, and then subsequent 8 cycles of Pembro alone, so a total of 14 Pembro adjuvantly. This was the experimental group. Control group, there was no neoadjuvant or adjuvant therapy. A very small proportion of patients got adjuvant immunotherapy in the control group of trial. Key results, pathological complete response rate in all comers, intent to treat population, 57%. And if you look at the patients who had radical cystectomy, 65% pathological complete response rate with Pembro EV neoadjuvantly. Overall, impressive event-free survival, hazard ratio 0.4, Pembro EV better than no perioperative therapy, and overall survival benefit, hazard ratio 0.5, favoring Pembro EV. Toxicity was as expected. We have to pay very close attention to that. Toxicity, neuropathy, skin rash, pruritus, fatigue, appetite, taste changes, diarrhea, sometimes weight loss. But overall, the reassuring finding was that patients had radical cystectomy in both groups in a very similar fashion. So the AV Pembro did not compromise the ability of patients to undergo curative intent radical cystectomy, and also there was no significant delay to surgery either. So that was reassuring overall. I'll stop here to see if you have thoughts and reactions, Sadi.
Wow, this is Did they have any correlative for this particular study, any correlative data on biomarkers and ctDNA and so on?
This is a big quest. We actually asked them to work on ctDNA. They did not have biomarker analysis in the current presentation in the interest of time. It was about 12-minute talk or so, but I know they're working on ctDNA in parallel, and I'm sure they will probably have tissue available and plasma available for other biomarkers. I made my plea and I asked for biomarker work as I always do in these trials. And I think more to come. We have not seen the manuscript yet, but I think this is coming. And I would say that based on the discussion by Dr. Rosenberg, that was great. Overall, I think this is a paradigm shifting, in cisplatin ineligible patients with these impressive results. The big question remains of the total trial population, only 60%, 6 out of 10, received the adjuvant component. The other did not for whatever reason. So the big question in my mind is, does everybody or somebody or who needs the adjuvant therapy component? I think that will be the big question we're going to find out in the future. For the moment, until we find more substance analysis biomarkers, I will probably take the trial per design as it is for implementation based on tolerance and side effects, of course.
Yeah, and before we move to the next trial, I mean, the one thing I always view in muscle invasive bladder cancer is if there is a way that you can actually decide which patients you can give them chemotherapy or target therapy or chemotherapy plus radiation therapy and spare the surgery, don't do the surgery, that will be amazing if you achieve a cure using some of these novel therapies. So that would be key.
For sure. I think this is a very big quest, and there are trials looking at that question, Sadi. I think there's a trial, I think it's called SWOG 2427 by my dear friend Dr. Leslie Ballas in Los Angeles. This is through SWOG, and what they do is patients who get whatever neoadjuvant treatment, EV Pembro, chemoimmunotherapy, whatever they, let's say neoadjuvant or induction therapy is, if patients, refuse radical cystectomy, midway, and they have a cystoscope and TURBT, and they have I think it's a good downstaging, like clinical complete response or downstaging. They have specific parameters, about that. They may go to bladder preservation with radiation plus pembrolizumab in that trial. I think it's called BRIGHT. That trial is a small phase 2 trial, but interesting. But overall, there are other trials looking at bladder preservation with systemic therapy alone, like the Hoosier trial by Dr. Galsky and Matt Galsky and colleagues. And I think this trial are going to define the future state. For the moment, I think we need either radical cystectomy or a radiation, maybe with a radiosensitizer for a bladder preservation approach. In the future, as we get better and better with effective systemic therapies and better with biomarker-based patient selection, we might get in the future that we may potentially have great control with systemic therapy alone, but we need to be careful and wait for the actual data.
Great. What's next?
We talked about this exciting data in the adjuvant meaning perioperative setting. And as I mentioned, there are trials now looking at blood preservation. I mentioned the trial by Dr. Ballas in SWOG. There are many other trials, of course, looking at blood preservation. But if we focus now on the adjuvant setting, and we have the data from IMvigor011, that Professor Pauls presented at ESMO on Monday afternoon. That trial took patients, Sadi, that had neoadjuvant chemotherapy or not, or just after radical surgery, no prior immunotherapy naive, and these patients got randomized to adjuvant atezo versus placebo based on ctDNA positive status using the Signatera tumor-informed assay. So patients with ctDNA positive, either from the get-go after cystectomy, or later, because they did serial testing, those patients who had ctDNA positive after cystectomy or later after serial testing, they got randomized to atezo, anti-PD-L1 versus placebo. This was a positive trial for disease-free survival and overall survival, clearly positive. ctDNA negative patients who were post-cystectomy negative and remain negative serially did very well. And I think event-free survival was very high for those patients. Only about 10% or so had recurrence in the ctDNA negative group. Of course, if you ctDNA negative and you remain, you have more time points, you are destined to do better, obviously, strongly prognostic. But the ctDNA positive patients, again, benefit from atezo. The big question is what we implement in clinical practice. I think, number one, to me, ctDNA now has shown not only robust prognostic role, but also strong predictive role in this particular scenario. I'm not ready, though, to extrapolate the data from the IMvigor011 to Niagara or to EV303 trial with EV-Pembro. I would like to see the ctDNA within those subsets. And we did see the data from Niagara with ctDNA. And my take on it is that for the moment, I'd use the durvalumab with the Gemcis durvalumab neoadjuvant and adjuvant durvalumab regardless of ctDNA or path CR
But
status.
why?
So
But
a little
why?
bit
But why?
differences.
But why though? I mean, if you have the ctDNA in the IMvigor and you see that the ctDNA negative, they're not benefiting from adjuvant atezo. Can't we? I know you can't accept, but it just you can't really do a. I mean, you can't do a study for every single IO agent. So you don't think that this will allow you to not use adjuvant IO if the ctDNA, you're not ready to withhold adjuvant IO for ctDNA negative patients?
Great question, Sari. The reason I'm not ready to extrapolate and I'm still inclined to use adjuvant durvalumab in the context of the Niagara regimen is the data we saw by Tom Powles at ASCO this year. It was a little bit surprising to me, but he showed the slide that patients had ctDNA post-cystectomy, and about 90% of those patients had ctDNA negative status post-cystectomy after neoadjuvant treatment and cystectomy. Only about 9% had ctDNA positive status. So majority are ctDNA negative. And within that subset, let's say, they saw that the curves appear to separate, of course, small numbers, very small events, so number of events, so it's hard to be conclusive, but there's some separation of the curve, even with the PCR subset, with PathCR, within the negative group, there seems to be a separation with durvalumab. Now, is that because of the neoadjuvant durvalumab? Is it because of the adjuvant durvalumab? Hard to tease apart. But for now, between the risk of overtreatment and risk of undertreatment, if the patient tolerates durvalumab well, usually, it's 8 monthly doses. So usually they tolerate it well. So I'm inclined to, go with adjuvant component in that context. Again, acknowledging it's not perfect and we may overtreat some patients.
Makes sense. Okay, next.
So the last one is metastatic disease frontline. Our colleagues and friends from the Chinese group actually presented the data from the RC48-C016 trial, disitamab vedotin plus toripalimab, DV toripalimab. This is an antibody drug conjugate against HER2 plus a checkpoint inhibitor. This is a combination that reminds us of enfortumab vedotin plus pembrolizumab. This is two different drugs, so it's disitamab vedotin and a HER2 antibody drug conjugate carrying the same payload that enfortumab vedotin, the MMAE microtubule disruptor. And the toripalimab is a different checkpoint inhibitor, but similar class with pembrolizumab. That combination definitely was very superior compared to platinum chemotherapy, Gemcis or Gemcarbo. There was a significant improvement in overall survival. Hazard ratio was impressive. Similar degree of benefit with the EV302 trial with EV-Pembro versus chemo. So overall survival, progression-free survival, and overall response rate, all of them were impressive. Just to give you a sense, the overall response rate was 76% with DV toripalimab, but we saw very low number of complete responses. So that was one of the differences. The complete response rate was approximately 29% with EV Pembro, and was very low, single digits with DV toripalimab. We don't know, exactly why it was the case. The colleagues from China mentioned that maybe patients with lymph node disease only metastasis was a small proportion. I think there were some patients with upper tract disease. About half of the patient population in the Chinese trial had upper tract disease, higher proportion than the other trials. So sometimes it's hard to get a CR with the upper tract tumor. Nobody knows for sure why the small CR rate. Having said that, I think it's practice changing in China. In the rest of the world, we're waiting for the DV, disitamab vedotin anti-HER2 ADC plus Pembro phase 3 trial compared to chemotherapy. Academically speaking, the control arm was suboptimal, you can say, because it did not incorporate maintenance avelumab, and a few patients got immunotherapy later. Having said that, the degree of difference was so impressive that even if the control group did somewhat better, still would have been a positive trial. So definitely practice changing. I think the degree of benefit with DV toripalimab compared to chemo is similar to what we saw with EV Pembro, just different parts of the world, because the EV Pembro is not available in China, and vice versa. So I think overall it's impressive results, and the field is moving forward.
In the countries that don't have the EV Pembro.
Exactly, and until we're going to see data probably in the near future, Sadi, in the rest of the world with DV, disitamab vedotin Pembro versus chemotherapy. The trial is ongoing, is accruing probably, mostly ex-US. And to your point, there are many countries that still may not have access to EV Pembro. So that's it's a challenge, a separate challenge about availability and access to therapies.
So my last question, and I'll let you go, and it's not related to how Leon is always wrong about baklava. We all know he's always wrong. You're right, he's wrong. But since ESMO 2025, what is the one thing that you are going to implement clinically that is different than before ESMO 2025? Or is the data is great, impressive, but in clinic, when you're seeing patients in clinic, nothing has changed?
Two things. I think based on what we discussed, I think we're all waiting to see the regulatory approval for EV Pembro and formovedotin pembrolizumab for cisplatin ineligible patients with localized muscle-invasive disease. I think the data is immediately practice changing, in my opinion, with impressive results. The question is when the regulatory approval will come, and secondly, how much people will start to look for reasons to not give cisplatin. How much are you going to try to find reasons for cisplatin ineligibility? Are we going to have more hearing tests done? Are the audiologists going to be more busy? We don't know. Obviously, we have to wait for the EV304 trial comparing EV Pembro to Gemcis. That's a separate trial for cisplatin eligible patients. But I think this is probably the most robust data set with practice implications right now in localized muscle-invasive bladder cancer. And the separate question will be the role of ctDNA. I think I can now say formally that ctDNA is robustly prognostic and also predictive in the context of IMvigor011, with the caveats we discussed that it's hard to extrapolate to other trials.
Dr. Petros Grievous, the king of baklava. I hope you win the second annual BGT Baklava Award and take it from Balaj Halmos next year.
I look forward to that. I was very happy about Balaz. I think he deserved the baklava award. I think that Leon Platanias is right, though. I have to, to correct you, because, the baklava with walnut is the original one.
I can't argue with the Greek god. Dr. Petros Grievous, thank you so much for coming on Healthcare Unfiltered Express.
Thank you, my friend. Great podcast as always.
Thank you for listening to this edition of the Healthcare Unfiltered Express. Until next time, take care.